love someone? Have you ever cared? Do you miss someone? Have you ever shared?
Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The title for our program tonight is New Trends and Developments in Healthcare Delivery. It is apparent that many major changes are taking place in the healthcare industry. Some of them are so profound that they are called revolutionary. Obviously, the outcome of these changes will have a significant impact upon the future of our healthcare delivery system. And in order to cover this broad subject, we'd like to produce two segments of the same show tonight. And I'm very happy to announce the presence of three distinguished and articulate speakers who all hold important functions in our medical community to participate in this discussion tonight. And let me introduce them. Hi, Dana Drew is the administrative director of the Good Samaritan Health System. Hi, Dana.
Hello, hi.
How are you tonight?
Fine, thank you.
Dana is in charge of the occupational medicine program, and I'm very happy to welcome here tonight to our show.
Thank you for having me.
It's good to see you. Our second speaker is Dr. John Granado. Dr. Granado is a urologist in practice in San Jose, and he was the past president of the Santa Clara County Medical Society. Welcome to our show.
Thank you very much.
Thank you for being here tonight. And our third speaker is Dr. Richard Hankey. Dr. Hankey is the director of the emergency department at the San Jose Medical Center, and he was recently elected to be on the board of trustees of the Good Samaritan Health System also, and we're very honored to have him here tonight. Welcome to our show.
Thank you, Han.
Okay, ladies and gentlemen, maybe you can give us an account as to how the recent changes have affected you and your career personally.
I represent a segment of healthcare that is different than hospital-based medicine. Mm-hmm. In occupational medicine, we are dealing directly with employers and injured workers. And I think the biggest shift that we are seeing is that we have to deliver programs that are driven by the client's need more than being driven by what the healthcare system thinks that it needs.
I see.
So the contrast is that the client, or what would be the patient in other arenas, is a very active participant in deciding what it is we do and how we do it.
Mm-hmm. So there's direct accountability at least from the employer's part to choose the right plan.
Absolutely.
Okay. Dr. Granado?
Well, I guess not unlike, most of the physicians in the community, seeing fewer patients in the office. In my own case, that's led me in some new directions. I work part-time as medical director for quality assurance at Alexian Brothers Hospital, and I'm currently involved in the development of the Medi-Cal managed care plan here in Santa Clara County, mm-hmm. which I think will create a very dramatic change in the practice of medicine, certainly for Medicaid patients.
Dr. Hankey?
Well, in the emergency department, there's a lot of things that are different. Usually you just had to worry about taking care of all comers. Since the advent of managed care, which has been over 10 years, you have to worry about whether a patient's care is going to be authorized, which really means if anybody's mm-hmm. going to be willing to pay for it. The pendulum has gradually swung to the point where cost control is one of the dominant concerns with regard to patient care. In fact, it's become so dominant of a concern that you're starting to see some signs of a consumer revolt in some areas, and the pendulum's starting to swing back the other way. Mm-hmm. Emergency physicians are always having to deal with managed care organizations, and by the nature of managed care, it's meant to save money. These organizations can vary immensely in how they approach things. Some are very conscientious in how they employ protocols and try to make sure that the doctor-patient relationship remains paramount. Some are willing to sacrifice in order to save money.
Yeah.
But we've got to take care of all the patients irrespective of whether or not they get paid for.
Yeah. You know, from the outset, our show, America's Healthcare Crisis, was conceived in terms of providing a forum for the expression of ideas that improve the efficiency of the healthcare delivery system in 3 arenas: accessibility, affordability, and quality of care. Actually, accessibility and affordability, even though they're hard to define, but we can get around it. But quality of care is something really is tricky. How do you define that? Because for me, and actually my recent research reading, I have with me the copy of the article in the Time magazine, the September issue, that is entitled "The Best Way to Improve Medicare." And they cite one of the main reasons why medical economics do not follow the usual law of economics, and that is, it's very difficult to define what quality care is. It's not like buying a cantaloupe, you know. You can open it and taste it, know right away. So what is your perspective about quality of care?
Well, I think one of the changes that we've seen over the last several years in the practice of medicine, quality is being defined more by people outside of medicine than people inside of medicine. And some of that is the influence, certainly, of the legal profession, and that there's been a lot of defensive medicine practiced as a result of that. But one of the phenomena that's happening that we're seeing certainly in occupational medicine is the development of protocols that somehow the intent is to create quality. And I think one of the concerns that the people in our program have is that sometimes these are done without real regard or understanding for clinical practice. And what may look good on a piece of paper in an administrative setting may not be appropriate or factor in all of the issues that happen in day-to-day encounters. And so one of the things that we're trying to do, for instance, in our program, is collect clinical data to help shape those protocols so that they're based more on real-time practice than theory. But it takes a while to develop that.
Yeah. I feel that the problem with defining quality is it's very often time is a matter of perception. Even very educated people don't know what quality is all about. They think that more is better, for example, which is certainly not necessarily true. As you probably know, I mean, 1/3 of all MRI is abnormal and doesn't mean anything. So, I mean, what do you think? What is your opinion as a specialist could be defined as quality care in urology?
Well, you know, the final word hasn't been written on quality yet. Paul Elwood, who actually coined the term HMO, it was his hope that managed care would compete on the basis of quality, and that hasn't happened so far, primarily because we haven't been able to define it. Economics influences what we perceive as quality. There's no doubt about it. For instance, there was an article just this week in Urology Times, which is kind of one of the pulp magazines, by a physician who was in practice at the University of San Francisco and then went to Louisville, Kentucky. And he looked at TURPs, operations on the prostate, which is one of the most common operations that urologists do. And he found that in Kentucky, there were many fewer TURPs being done than there were in San Francisco, but the weight of resected tissue was much greater. And he concluded that because there was more to do for urologists in Louisville, Kentucky, they waited longer to do the TURPs, and when they did them, they actually had more tissue to resect. Now, you know, who's providing better quality? The people in San Francisco or the people in Louisville? I really don't know. You can certainly make arguments on both sides, but we haven't accurately defined quality yet, and that's one of the problems.
And I think you bring up a really valid point that it's often very much geographical. What is standard of practice in California or in the West Coast is very different than what would be standard of practice in the Midwest or the East. And the phenomena tends to be that it starts or the history has been a lot of it starts here, such as HMOs and the managed care and the quality movement. But that's not to say that they haven't been practicing quality medicine in other parts of the country.
But, well, that's when you get into outcomes analysis, and that's
Right.
the cutting edge stuff right now. And of course, you don't have the last word in, you don't even hardly have the first words out on outcome analysis, but the idea of that concept is that you're going to take relatively large groups of people so that the results are going to be statistically valid and track their outcomes over time with different therapeutic modalities and find out who's going to be better off in the long run. And you really need something like that, because when you try to find out what quality is, a lot of it is in the eye of the beholder.
Yeah.
If you ask your average layperson,
Right.
what is quality? Well, they haven't that much medical training, and it's a physician who's going to look them in the eye, talk to them like they're a real human being, spend some time with them, establish rapport, care about their concerns. And to be honest with you, I've known physicians who were able to do this who really did not know that much medicine. I found out when I was a third-year medical student that if I spent time with my patients, and of course the medical student's supposed to do that because the residents are too busy, that the patients would ask me if they needed the operation that the senior resident proposed for them, and I barely could spell the operation, let alone tell them the indications for the surgery. But since I'm the one that established rapport, they turn to me for advice. So that's how a lot of people define quality, is how they feel about their interaction with the physician. And we know in the medical profession that isn't really quality, but that's the best that a layperson can use to judge on.
Or did I get well?
Yeah.
And that's
Well,
a subjective
there are two issues
issue.
here. The first thing is the time, but the time by itself is not a sine qua non of quality. It's quality time. I mean, sometimes you can very effectively spend a few minutes with a patient, and it means a lot. Or you can hang on for an hour, it doesn't mean anything. So, and the outcome also is not the issue, because especially I have been in primary care for a long time. And if 100 children come in with a cold, you give them a glass of water, some Tylenol or a shot of penicillin, the outcome is the same. So for all of them, they cannot equate the outcome and the quality of care necessarily. It's a very difficult issue, and I'm glad you mentioned that, because oftentimes it's a perception, and it may not be scientific at all. Because, for example, pain, how can you measure that in terms of being objective about it?
If managed care achieves its most idealistically measured outcome, it will really improve the results of health for a lot of people. The problem is, some managed care organizations do that and some do not. My father lives in eastern Pennsylvania. It's a rural area where they don't have that much managed care. He's a very healthy, athletic person in his early 70s who still is employed and was recently hospitalized for a week for a minor infection. That would never happen in California in a managed care environment. And here you took a healthy, older person, put him in the hospital, where he has a much bigger chance of getting a severe complication than he did where he'd have been treated at home. That's a case where managed care would have improved, in my opinion, the care. But then you can also see where corners are being cut unnecessarily and to the patient's detriment.
Right. Let's talk about the issues of accountability here. Again, I'm referring to the article in Time magazine entitled "The Best Way to Fix Medicare," and they cite 5 reasons why the Adam Smith's laws of economics don't apply in medicine. And the first 3 have to do with lack of accountability. The first reason is that people are insured, so it's not a cash economy. I mean, it's paper economy, it's other people's money being spent. The second reason is that even people who are insured don't buy insurance, they're subsidized through Medicare, Medicaid, whatever. You don't even pay for the insurance. And the third reason is that the decisions on whatever is being done are determined by the physician, who do not pay for what he ordered either. So there are 3 lack of accountability right there. So I mean, that's why we're in such a sort of financially bankrupt situation, because people are spending invisible money. So there comes the concept of capitation. I guess capitation would correct some of that, don't you think? Because at least it puts the responsibility in one of the major players, who is the physician.
Well, but it doesn't put any responsibility on the consumer.
Right.
And many times the care is sometimes driven by consumer demand. If the answer isn't quite what they'd like it to be, or they have a fear that there is something else going on. Part of the problem with capitation is it doesn't share that accountability between the provider and the consumer. Even with
maybe, excuse me, maybe you can define capitation for our viewers, because they may not know what it is about. I mean, our viewers may be lay.
So it's
audience.
a lump sum payment to take care of all the patient's needs.
Okay.
So if you're a primary care physician, you're going to get X payment for each member that you have enrolled in your practice for each month. So much per member per month. So if you have, for instance, 10 members of this plan and they're paying you $10 per member per month, you get $100 every month to take care of everything these 10 people need. You just hope that they're not going to get sick.
Yeah.
Theoretically, this should place more emphasis on preventative care, which is very good.
Right.
You know, of course, a lot of people already have disease before they are enrolled in the plan, and the downside of it is that people may be denied needed care because they run into somebody's limited budget.
Well, I mean, I see more of a positive side of it, because there will be an incentive for the physicians to educate patients, keep them well, keep them out of the hospitals, keep spending unnecessary medical expenditure on things that are, you know, I mean, in the fees, for me, for a long time, I saw the writing on the walls for the fee-for-service kind of system. Because, I mean, you know, in a sense, the incentive is to spend and spend and spend. And, you know, I mean, there were physicians at the time who owned labs, who owned x-rays, and, I mean, you know, just spent all over the place. And I just think that it is one of the main reasons why the system is really going bankrupt, because of so many unnecessary things were being done at the time. You want to say something about that?
Well, you know, it's very easy to provide too much care. It's a little bit harder to provide too little because there are people watching you. But the hardest thing of all is to do what's just right.
Right.
That takes a lot of thought. And that's part of the problem. If you're in a managed care situation where you're receiving capitation, that's based on risk spread over a large number of individuals. That's the only way it works. You've got to see lots of patients, you've got to see them efficiently, and you may not spend enough time thinking about that individual patient's problems to decide what's just right. In the fee-for-service environment, we worked around that by ordering all kinds of tests. If you order all the tests, then the chances are you're not going to miss a problem. In the capitated environment, if you order all those tests, you're probably going to go belly up. You're going to go broke. So the temptation is to assume that there really is no problem, and therefore you don't need to order the tests, and that's when patients get hurt.
It's interesting what you say, because again, we come to the notion of quality time. It's not so much time you spend on a patient per se is an absolute, but the quality of the time you spend with them. I say that's from the viewpoint of a pediatrician. I used to practice pediatrics, and I spend a huge amount of time on the phone. And very interestingly, recently I came across an article which promoted the idea of internists, pediatricians, family practitioners spending time on the phone instead of seeing the patients. And I think that is very healthy development, because we really have to train ourselves to get trained to communicate with the patients. Because for me, especially in primary care view, the communication part is crucial, because we don't do too much. We teach a lot, we educate, whatever. You going to say something?
They did a study on that very topic in the New England Journal of Medicine, which was very revealing to me. The study was done several years ago, and they evaluated the quality of telephone advice given by attending physicians, physicians in training, and nurses. The telephone advice given by the nurses was hands down the best.
Okay.
Next was a physician in training. Attending physicians were at the bottom of the list.
Yes.
And it's not that I disagree with your point. I think physicians should be more attuned to this, but historically they have been more attuned to what they do in their practice, in the office, in the hospital, and have given telephone advice short shrift.
Yeah.
Well, you're actually confirming what Hung's saying, which is that it's a communication skill, which is the art
Needs to be
rather than the
learned.
science.
We're not trained in doing it.
No, not at all. And the focus in medical education has been in the sort of scientific diagnosis of a problem, when what I think you're promoting is the concept of the art of communication and,
Yes.
and talking and listening, and
Yeah.
that perhaps because that's a big part of nursing education,
Right.
the
right.
nurses were perhaps
Yeah.
more attuned to that.
Yeah, that's one of the main objections I have in terms of the quality of our medical education. Doctors are trained to diagnose and to treat more than to spend time communicating with the patients. And to me, that's a big deficiency. It really is, especially in primary care, because we don't do very much really. And I'm just saying that out of the many patients with a minor conditions, it's just a matter of motivating them to do the right thing, which is really very cost effective. It doesn't have to do procedures and expensive stuffs. But you going to say something?
Yeah, I have a friend who's on the board of a malpractice company, and he confirms exactly what you're saying.
Mm-hmm.
Physicians who don't communicate well with their patients get sued.
Yeah.
Quality of care being equal. You
Yeah.
spend time communicating with your patients,
Yeah.
they tend to like you,
Yeah.
and they listen to what you say.
Right, right. But again, the system has to give the incentive for that skill, because I used to spend hours and hours trying to motivate, to educate, which really keep the cost down and improve the quality of the relationship and the care. But I did not get compensated for it. Whereas Zoom, you go in and you put a tube down the throat, or
In managed care, you
replace
do
that.
get compensated for that, at least indirectly, because if
Yeah.
the health of your enrolled population is better,
Mhm.
then there will be less money spent on their care.
Yeah.
And those who are, have an interest in the risk pool,
Yeah.
which the viewers probably don't know what that is.
Yeah.
And this was just exposed on 60 Minutes. They were talking about financially incentivizing
Yeah.
physicians to control costs. A risk
Yeah.
pool is money that you share at the end of the year
Yeah.
if you meet certain financial targets with regard to utilization.
Yeah.
And then you get into a whole interesting bunch of ethical dilemmas
Yeah.
and quality dilemmas as to
Right.
what kind of guidelines you're going to set to make sure that quality of care is upheld,
Yeah.
cutting back only on that which is superfluous and not that which is necessary. As Dr. Granado says, trying to do just the right thing.
Right, right.
Not too much and not too little. That's really
Every time.
difficult.
Every
Yeah.
time.
Right, right.
Yeah.
Actually, I watched that program last night too, and it's very interesting because again, it's very difficult to explore the globality of an issue. For example, they put a lot of emphasis on that case, which to me was totally mismanaged from the beginning. Very unfortunately, that lady who was so young and had cancer. That primary care doc just messed up the situation from the very beginning. It's very unfortunate because that was blown up. Well, one case sort of tarnished the whole situation in primary care because it was obviously mismanaged from a very basic viewpoint.
And that happened to my grandfather, and that was before the managed care era. He died of the exact same cancer with the exact same misdiagnosis.
Yeah.
And it had nothing to do with managed care.
But it's not the misdiagnosing, but the uncaring attitude that was, I'm talking about. The patient was bleeding and was trying to get him on the weekend, and he scolded them. He said, "Don't bother me, don't call me on the weekend." Right? That was, to me, it's not a lack of diagnostic acumen, but it's a lack of caring, period.
That's probably more common than you'd like to think. Most
Yes.
nurses can tell you stories about calling physicians at home after hours for pain medication order or whatever and being told, "Don't bother me at this point in time." That's
And
unfortunate.
that's a dilemma
But it
for
happens.
the rest of the healthcare providers.
Yeah. Well, actually, I think that we are pretty soon out of time. But let me make the last point is that I feel that the physician should spend time more effectively in that he should become a leader of a group. Like, he should be using his training and knowledge to lead a group of other people, like nurses or PAs, whatever, to do the communication part, and he can sort of more effectively use the health dollar. In that, I just feel that a physician with 8 years of education and 4 more years of training should not be seeing colds and coughs and and things like that, which we do, and taking sutures out. That's totally inefficient. But again, I think we're running out of time. It's very exciting because when things are animated and we have fun, things go by very quickly. So, ladies and gentlemen, we have just finished the first segment of our program on new trends and developments in healthcare delivery. I'm Dr. Hung Vu, and would like to invite you to watch our next segment, which is the part 2 of the same subject. So thank you for watching. So long. See you soon. Good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Have someone to stay through the years. Let me be the one now that I am here.